Good afternoon, everyone. My name is Priscilla Toral. I am the Senior Manager of Lupus Support and Education Programs at Hospital for Special Surgery. It is a pleasure to welcome you all to our live stream, Living Healthy with Lupus program, a program that's been sponsored by the Department of Social Work Programs for the past 14 years. The Department of Social Work Programs at Hospital for Special Surgery offers more lupus support and education programs than any other hospital in the country. Our programs are all free and are available in English, Spanish, and Chinese. And this year, we're excited to partner with the Lupus and APS Center of Excellence at HSS. For more information about our support programs and the Lupus and APS Center of Excellence, please visit our website, which will be included in the chat box. I'd like to begin today's webinar with a few brief housekeeping rules. Participants will be muted during the presentation. However, we're highly encouraging you to please use the chat icon on your screen to submit your questions during the Q&A portion of the program. I'd also like to thank those of you who submitted your wonderful questions at registration. Dr. Lockshin will be addressing these questions throughout his presentation, as well as live from the chat box during the Q&A portion of the program. Lastly, your feedback is critically important to us, and we ask you that you not leave us today without sharing your feedback in our evaluation, which will be embedded in the chat box at the conclusion of today's program. At this time, it is my pleasure to introduce Dr. Michael Lockshin, who is the Director of the Barbara Volger Center for Women and Rheumatic Disease at the Hospital for Special Surgery. Dr. Lockshin received his bachelor's and medical degrees from Harvard University and his clinical training at Cornell and Columbia Medical Centers. He is also a professor of medicine and obstetrics gynecology at Weill Cornell Medicine. In the past, he has held the positions of acting director of the National Institute of Arthritis and Musculoskeletal and Skin Diseases, National Institutes of Health, and editor-in-chief of Arthritis and Rheumatism, a leading rheumatology journal. He is the author of more than 300 scientific papers, textbook chapters, and 3 books about doctor-patient relationships, including Guarded Prognosis, Dancing at the River's Edge, and Time, Uncertainty, and Chronic Illness. Currently, Dr. Lockshin heads a center that focuses on issues special to women with rheumatic disease, including pregnancy. And today, Dr. Lockshin joins us in addressing concerns related to overall SLE management in the time of COVID-19. So I'd like to officially welcome Dr. Lockshin and thank you for sharing your expertise with us all today.
Okay, thank you, Priscilla, and thank you all for joining this. It's going to be, from my point of view, a fairly informal session, and I'm looking forward to the questions. It's a sunny day in New York, and we're kind of hoping that that's an omen for quick end to this awful period that we're going through. Obviously, you and I and everyone else has been deeply impacted by the COVID-19 epidemic, and we'll talk a little bit about how that affects you, how that affects lupus, and what we're learning about it. So next slide, please. Okay, just one brief comment, because I think everyone pretty much knows that lupus is not equally distributed throughout the population. Obviously, it's almost all female, 90% or so, but there are also a large number of discrepancies in that non-white populations seem to be more susceptible to lupus than white populations, and there's a gradient there from Europe to Asia to and so on. Well, it turns out for reasons that may be similar, the COVID-19 epidemic has also been disproportionately affecting minority populations. I put on this slide some things that have been reported in the press. I don't have any direct information on the data, but for instance, in Cook County and Chicago in Illinois, the COVID deaths are about twice that in the minority population as they are in the white population. Michigan reported at least that maybe as much as 8 times higher, and Louisiana also. Louisiana is different. In New York, and I don't understand why this will be, there are still the differences, but less so. So if you can read that, New York has about a 22% Black population, but the deaths are about 28%. And in Hispanics, New York has a 29% of the population, with 34% of the COVID-19 deaths. There are obviously a lot of reasons for that. Much of them have to do with housing, use of public transportation, crowding, availability of medical care, and so on. I'm not going to get into a lot of that, but I can speculate if you're curious. Next, please. So we're going to go forward with some of the general questions that you've asked. These are the ones that showed up most often, and I'll try to take them one by one. Next, please. So one of the questions was, given the recent enthusiasm about the antiviral drug remdesivir, the question came up, can people with lupus who do get COVID-19 take remdesivir? And the questioner noted that obviously we don't have clear answers, but they wanted my opinion. And the answer is yes. There are many antiviral drugs that have come up over the past several years, and you see them advertised on television. There are drugs for HIV, there are drugs for hepatitis C, there are drugs for other types of viral illnesses, and they're all given to lupus patients who also suffer from those sort of things without any particular problem. While we don't have direct evidence of remdesivir in lupus patients, all the history that we have says that this should be perfectly safe and effective to use in lupus patients if they're unfortunate enough to develop the COVID-19 illness. Next, please. Do you know if the vaccines being tested use dead or attenuated live virus? I'm asking because I have always been told that lupus patients should not take vaccines that use live virus. And that statement is true. The live viruses are chickenpox, shingles, the MMR, or measles, mumps, rubella vaccine that children get, and if you get the annual flu vaccine, the one that you take through the nose by sniffing through the nose, those are live viruses. And generally, because we're a little bit worried about how lupus patients handle virus infections, we advise that they not use it. The vaccines that are being developed for COVID-19 are not live viruses. Repeat that, they are not live viruses. They're virus parts. They're parts of that could be proteins on the outside, those little red things that you see in those pictures of the virus. It could be the internal instruction, which is referred to as RNA. There are many, many different viruses that are being used. They should be safe for all lupus patients. There are questions that we can't answer right now, is whether these viruses will in fact adequately immunize patients, although data suggests that that's going to be true, and that we also need to know whether those new viruses will cause unusual side effects that we don't expect. And so far also the preliminary data says that it's not true. So not live viruses. If and when a final vaccination is approved, you should take it. Next, please. Should you take the flu shot this fall? The answer is yes. The COVID-19 virus is a completely different virus than the annual flu virus. It's a different, for instance, if you get immunized to polio, that doesn't make you immune to measles or mumps. You have to vaccinate someone, you have to vaccinate them for the very specific virus. So being exposed to or even having COVID-19 does not in any way protect you from the annual flu. You should get the injectable inactivated viruses when virus vaccinations for flu when they come around this fall, but you should not use the nasal mist flu vaccine because it's a live virus. Next. I'm told the COVID antibody test is IgG. How is that different from the IgG you test for lupus? Okay, this is going to be a little complicated explanation, and I apologize because it's Dr. Double Talk when we use terms a lot. There are two, when you think about antibodies in general, you can think of it as the type or class of antibody. I'll come to that in a minute. Or you can talk about the antibody specificity, which is what is the antibody trying to get rid of. The important question that you want to ask right now about the IgG is its specificity. What is it fighting? And in this case, if you have an IgG antibody to the coronavirus, you're fighting that. If you have an IgG antibody to measles virus, you're immune for that. But you can also have antibodies to things that are not viruses, like your own body parts, which is what happens in autoimmune disease like lupus. If you get an IgG test for COVID antibody, you are being tested to find out, whether you have had this infection. Not whether you have it right then, but whether you had it several weeks ago. Now, some of the other antibodies, and possibly some of the viral antibodies, not only get rid of infections, but they cause other damage as well. And that's what we think about as autoimmunity. Next, please. So we talk about the antibody specificity, or what is it fighting when we use the term, what is it directed against? Generally, it's an infection, and it's there when you make your antibody, that's part of your way of getting rid of that infection. But when it goes awry and starts attacking part of your own body, it causes damage, like in lupus. The COVID IgG test will tell you whether you had the antibody, and it usually isn't clearly positive for at least 3 weeks after you get the infection. Doesn't mean it's not there, just means we can't measure it well because it's not there in high enough amount. It's also true that if you have IgG antibody to COVID-19, you're probably immune to that. You probably will not get it again, but that's not 100% certain, but it's reasonably certain. Next, please. Then just briefly, and again, I don't want to confuse you too much, but when we talk about the antibody types, I'll just briefly tell you there are 5 types of antibody. The IgG is the one that generally means you've had an infection and it's been there for a while, and it means you're immune. Early on, before IgG comes up, IgM antibody is sort of the early start of your ability to make antibody. So oftentimes in a week or two after an infection, you'll have IgM antibody and it'll gradually switch to IgG, or both will stay. IgA, you don't hear much about, but it's all the moist surfaces of your body have IgA. There's a kind of new interest in IgA because since the coronavirus appears to go in through the lungs, it's a moist surface, the IgA response may be more important as well, but that's not much known. And IgE is what you get hives or anaphylaxis from, and IgG we don't know very much about at all. And if you want more detail of this, I can give it, but that basically is why you talk about IgG and IgM is the timing of when the infection came about. Next, please. I'm told the COVID antibody test is IgG. How is that different from the IgG test for lupus? Well, I've sort of answered that. It's the IgG COVID test just simply tells you you have had COVID and you have had the infection in the past, whether or not you knew it. And the same way, if you were immunized as a child for mumps and rubella and those things, if you have the antibody, it means you were immunized and probably are protected. With regard to the lupus antibodies, we don't know where they come from, and typically they are to anti-DNA, anti-Smith antibody, and there are other things. Those are normal body parts, and if you have those antibodies, we don't know why you have those antibodies. We use it to say you have lupus, and in this case, we're more worried about what the damage the antibodies are doing than about what they're protecting. But one of the questions that's come up, and I'm going to come into this in a minute again, is that if lupus patient makes antibodies, and is the anti-DNA and the anti-Smith really a hint of something, another type of virus infection that we don't know yet about, but which looks so much like normal tissue that it makes you make antibodies against it? These are some of the interesting questions that are coming up with regard to the COVID infection. Next, please. What can you tell us about patients with SOE who are getting sick with COVID? What drugs are they taking? Do they have underlying issues like heart disease and obesity? Well, information is coming in very fast and from a lot of places around the world. And the answers are not 100% clear right now, but our experience at Hospital for Special Surgery in New York Presbyterian Hospital, and what we're hearing is that first, lupus patients aren't particularly more susceptible to getting the disease than are other people. That is, if you have it in a household or your workplace or something, you're not at any more risk than somebody else. However, if you do get it, it'll be basically your prior history. Do you have kidney disease? Do you have other sorts of problems? Are you on high-dose medications that will determine how it comes out? Because obviously, sicker patients are going to have a harder time with COVID-19 than are people who are not sick. There obviously became a very quick question about the hydroxychloroquine or Plaquenil, which I refer to as HCQ here. Does that actually protect lupus patients? And the answer is probably it does not. It doesn't harm them. And obviously, since it's helping treat the lupus, we like to continue it going. There will be more information on this in the next few weeks. Next, please. As communities begin to reopen, are there any special precautions people with lupus should take? For instance, if we are continuing to work from home and socially distance, but we live with those who are not, do we have to keep our distance from them? Well, these rules are changing virtually daily, and hourly if you're watching television. And it depends on where you are, what the risks are, and so on. By and large, I'm very much in favor of the most conservative regimens. That's the masks, the hand washings, the 6 feet distance, and so on. Your local local authorities should be informing you. I think the New York City and state announcements and Governor Cuomo's are really on target, and I agree with them. The HSS website is going to have frequent updates on this. Even in New York, different hospitals are doing things a little bit differently. If you have special issues, talk to your doctor to see if there are special rules for you. There's some websites listed, and I hope they'll be available to you after this is over. Next, please. If I'm on high doses of prednisone as part of my treatment plan, I'm at more risk for catching COVID-19 is my risk for serious illness worse. And that's the same sort of answer. You're not at more risk for catching the illness, but it's a problem if you do get it. One of the things I want to emphasize, though, is if you're taking an immunosuppressive drug, don't stop your medication without talking to your doctor. A sick lupus patient is at much worse risk than a patient who is doing well on medications. Most of the medications are protecting you more than they are putting you at risk. It's possible in some cases that it's time to taper a medication or something. You might spread out. Those are you on biologics. Some have spread out injections or infusions, say delayed for a couple of weeks or so on. Those are all possibilities, but it'll depend very much on who you are, what your relationship with your doctor is, and discuss it. Just don't make decisions on your own here. It's very important, and keep your disease under control is the most important thing. Next. I'm concerned about coming in for blood work and infusion treatments. What precautions can I take so I'm as safe as possible when I have to be in the hospital environment? Well, again, I can speak only for our local situation. We are really, really, really attentive to this. And the rules are changing rapidly. Initially, no one was allowed in the hospital, period, except as a patient. More recently, we're starting to open up with outpatient visits. The infusion room has special precautions. We have special distancing and PPE, that's the protective equipment things, frequent hand washings, and so on. The hospital physicians get virtually daily announcements about which areas of the hospital you can go to, about where you can go. For instance, patient appointments are being spread out and in separate rooms and so on. These change daily, and whatever is your easiest contact with the hospital is your best source of information, whether it's through the website, through your doctor, or through the infusion room, and so on. We'll tell you where we are today. We have Hospital for Special Surgery this week has begun to reopen, and as I said, just is changing very rapidly. Next, please. It strikes me, based on public reporting, the virus appears to kick off an autoimmune-like response in some people, almost mimicking inflammation caused by lupus, attacks on lungs, kidneys, blood vessels, cytokine storms. Are any rheumatologists studying this? Who? You will see in a microsecond that this is a really, really big deal, and we are looking at this really intensively. Next, please. Just to reemphasize it. Yes, a lot of COVID-19 looks like lupus, and a lot of lupus looks like COVID-19. And what we're trying to learn is what this is going to tell us about the both origins and managements of both diseases. Next slide, please. You probably can't read this. What it is just a clippings from newspapers and various other reports that have just been appearing frequently. I did put this together a couple of days ago. I could have added half a dozen more, but it talks about this thing called COVID toe with the reddening or blueness of the toes and the fingers. It talks about blood clots that are occurring. It talks about this thing called cytokine storm, which kind of looks like a childhood autoimmune disease that we refer to as Kawasaki disease. Basically, everyone is seeing this type of problem. Next slide. So there are some very strange things happening. And I'm going to invite you, if you want, in the chat or afterwards or follow-ups to this, to ask for details if you want it, because it's very complicated and I don't want to confuse people by getting too much into the woods here. I guess woods would be nice. I should have said too much in the weeds here. Is the blood vessel problem like that of lupus? And the answer is yes, very much so, but there's some kind of interesting differences, and we're trying to figure out what those differences are trying to tell us. The antibodies that people make in the COVID and the things like the COVID toes and so on, are they transient or sustained? Well, the difference between the COVID-19 patients and the lupus patients is that for those people who survive COVID-19, it seems to go away and not continue, although we're going to be looking at these patients for a long while afterwards. But it does ask us if we can understand for those people who develop the lupus-like syndromes and recover, what is it that makes them recover? Or conversely, what is it that they have or don't have that makes the illness stay on if you have lupus? We're doing a lot of studies right now to try to find answers. Obviously, things are moving very fast, and it's nothing is definitive, but stay in touch with us to hear what's happening. This is going to be a big deal. Next, please. One of the things that we're looking at, and again, and not trying to go too much in the weeds here, is that different stages of the disease may be telling us different things. The earliest thing is that the virus attacks the cells and probably just injures them directly, like, taking a knife and stabbing the cells or something of that sort. And that causes a kind of inflammation, and that isn't any more lupus-like than, say, a burn injury would be, or a car crash or something. Your body just recognizes that there's damage. After that first step, the second step is that the body starts to get rid of this reaction, which is making antibodies, making the cytokines that you hear about to repair the damage. And the biggest issue is that the controls on that repair may not be completely controlled themselves. That is, the reaction could be very much more than is needed, which is what's referred to as cytokine storm, or it could be making new antibodies like the antiphospholipid antibodies and causing clotting problems. That's what we're trying to figure out. Then later on, and this is when you hear about the people who are on intubation and so on, that happens when organs are badly damaged, and it probably doesn't make a lot of difference if you try to break the immune response or something. That's all repair issues, and it's a different sort of thing. So treatments and interventions of any sort are going to be very specific for the phase of the disease that you're in. Next, please. So bottom line for this is, if COVID-19 induces a lupus-like condition, what does it tell us about the origin of lupus? If it's a mimic of lupus but transient, If we know what turns it off, will that tell us something about how to turn lupus off? And will some of the treatments that work in COVID-19 work in lupus, or vice versa? There are studies going on to deal with each of these questions right now. And again, I'll just say, stay in touch. Next, please. Then a few other questions that came up, and then we'll hear some that came up too late for me to include in this. One patient says, I'm pregnant. Should I be more concerned about exposure or take any different precautions in relation to my SLE treatment and caring for my baby and myself? Well, obviously, we don't have a lot of information right now. We do have some information about pregnancies right now, and it's generally, it's all good news. First, risk for being infected isn't probably any higher than it would be if you were not pregnant. It's reassuring that the babies seem to be doing very well. We're not seeing things like congenital abnormalities or infected babies or anything else. And breastfeeding and so on seems to be fine, so long as you do usual and normal and self-protective things. Wash frequently, clean everything, and don't expose yourself. Those are the sorts of things. One of the things that has been a disappointment, and I think you've all seen, is that depending on the state of the hospital, and it's now different in New York City than it was a week ago, and it'll be different elsewhere, and it's different in different hospitals. If and when you go to the hospital to give birth, you may be subjected to extreme isolation if there's reason to think that you or someone near to you has the COVID infection, and that it includes spouses and things like that. New York Presbyterian right now is allowing spouses or partners in the delivery room, so long as neither is infected with COVID. Next, please. What do I need to know if I have to access the emergency room as a person with lupus? Well, this isn't just for COVID-19. This is rules that I use virtually throughout my entire practice life. Please carry with you a letter from your doctor explaining your particular problems, what medications you're on, what your allergies are, and what is a particularly worrisome thing for you. I'm not talking about your entire medical records, which can be hundreds of pages long. I'm looking for, I should think you would have a one-page summary that gives the essential elements. Now, a lot of people with their MyChart phone apps and so on will do this. I'm going to tell you, please keep a paper version of it as well. If by any chance you're unconscious or unable to use your phone, or your phone is lost or broken or doesn't work and so on, it won't help you. But it is useful to have on your person information specific to you. That information should include your doctor's emergency contact numbers as well. I really appreciated and never rejected somebody calling me from 3 o'clock in the morning, and even if it was I fell in the street, I think I broke my hip or something, having them contact me, because there's always something special your doctor knows about you that may not be obvious to an emergency room physician. And if you can, if it's an emergency room, touch base with your doctor first and inform that physician that you're going to the emergency room, and just keep them alert as to what's happening and what you're being told. And for instance, if some bizarre if the ER doctor says they want to do a procedure or give you a medication you've never heard of, don't hesitate to talk to your physician about that as well. Next, please. Seems there's more of a push to telehealth appointments. How are you handling examination or assessment of joints or other visible physical symptoms. Actually, we're very worried about this. Those of you know that there are lots of things, subtle things that may appear on the skin, or as you imply, the way the joints look and so on, that tell physicians something about you that won't be so easily visible on a telehealth appointment. We're trying to get a handle on this. We've sent out questionnaires asking for your experiences. We hope that you will respond to those questionnaires. It's a new world. We'd really like to know how you're experiencing it as well, so that we can make the best adjustments. Next, please. So my question for all of you, how's it working? And please let us know. Please let us know what other things, if we haven't touched on these questions or the ones that are going to come up in a couple of minutes, ask us. We are trying to get information that we can return to you so that we understand what it looks like from your vantage point as well as from our vantage point. And I think that's what I had as the introduction. Let's go on to the other questions.
Great. Thank you, Dr. Lockshin, for that really comprehensive overview. As we wait for some responses to come in regarding experiences with telemedicine, we're going to transition over to the Q&A portion of the program. Just a friendly reminder to please use the chat icon on your screen to submit your questions to Dr. Lockshin. Okay, so Dr. Lockshin, I'd like to start with some of the additional questions submitted at registration. And our first question states, as an outpatient gynecologist temporarily out in disability, what is the safest way for me to practice when I return to the office and hospital? So for example, should I be requiring patients to wear masks in addition to true routine screening our office will perform at check-in?
Yeah, that is really difficult, and I don't know that there are any real answers. Those medical professions that require very close contact, and OBGYN has to be one of the highest of those, they're high risks. And I don't have any specific rules to give you, except that I would recommend full PPE. Certainly if you're in an area where the virus is common. Now, we know that there are areas in the United States where it's very, very much less common, but somewhere like New York, I think I would use PPE, all of the PPE that is available, including all these instruments that you can sterilize and so on. Is for those things that you can handle without examination, then the 6 foot distance and the masks and so on are appropriate. But that's a very difficult one. I must say, I'll get political here. I cannot conceive of how tattoo parlors and things can be operating at this time. I think the danger is still high.
Great, thank you, Dr. Lockshin. So our next question is related to fatigue. I've had a difficult time with fatigue during the lockdown. Sometimes I sleep until 2 to 3 p.m. Is there anything that I can do to energize myself? Do you think that I may be having problems with sleep quality?
The answer is yes, and welcome to the crowd. I think everyone here has, including my household, including me, has been having this kind of problem because it's just our worlds are so completely disrupted. If you are able to take a sleeping medication, your physician's willing to prescribe it, that's fine. Getting up, moving, exercising, getting out to the extent that you can, all of those things are ways of tracking it, but it's a very difficult sort of thing. I do not want to recommend alcohol for people who are who have problems taking alcohol and so on. But if you're not on a lot of drugs, and you are able to have a glass of wine at night before going to sleep, there are lots of different things, but there's no answer for everyone. It's extremely difficult, and the best answer is going to be when this is over.
Great. Thank you, Dr. Lockshin. So we've had a few responses come in regarding to the experience with telemedicine. So we're hearing some varied responses. Some participants are sharing that it's going okay, and some are sharing that they're still kind of balancing that fear of exposure, or maybe just minimizing some of the seriousness of symptoms, and then realizing that a few days later they've actually gotten sicker. So could you share with us just some guidance for our participants on how to best optimize a telemedicine visit at this time?
Again, things are moving so fast. Any fever should be reported. Any new pain, and particularly chest pain, should be reported. Something that is very different from something that you have experienced before should report it. If in general it feels like this is another one of the variants I have of lupus or something on that order, you might be able to sit out and wait it out a little bit. But I think, and again, keeping in mind what your risk is, there's New York City is different from other places in the country. I would rather know your worry than not be informed. I think the greater danger is trying to decide this is not a problem and missing something really important. But it's going to be a judgment call, and different physicians will have different enthusiasm for it. One of the things you could do in telemedicine with the luck, or even if your physician allows you to email or something, you might get a 5-minute saying, nope, doesn't sound like a problem to me. Or it says, oh, I want to hear more about this. So opt to reach out rather than to keep it to yourself, please.
Thank you, Dr. Lockshin. So we have several new questions coming into the chat box, so I'd like to just post some of those at this time. And this question has come up a few times, Dr. Lockshin, in our chat box and in advance. How long is a patient on corticosteroids, immunosuppressants, and biologics able to postpone blood tests during the pandemic? I've previously had labs done every 3 months.
Okay, first, by the way, I see some of the names popping up, and a lot of them are people I know and love well, so thank you. I'm happy to see those names, and I guess I'll respond specifically later when we're off of this. Now, in terms of postponing blood tests, every patient is different. If you're in a position where you're seeing them, where your physician thinks every 3 months is fine, missing another 2 or 3 months is not likely to be important if you're feeling just as you normally feel. I will tell you again, when I was seeing a lot of patients, there are some people whose symptoms had worried me enough that I would want to hear from them virtually daily. And if I didn't hear, I would worry. And there were others, there's some things that, let's say a common thing is platelets are a bit low. Generally, you have 2 or 3 weeks to recheck. It's not going to get rapidly worse. You'll know in 2 or 3 weeks whether it's getting better. So I might say that, patient, let's check your blood every couple of weeks or every 3 weeks. Another one might be, have done well, and I've known the patient for 5 years, and she knows pretty much when her disease is coming back, and she's stable, and she might be in my 3-month or 6-month category, and so on. So it very much depends on you, what both your history is and so on. No absolute rules, but what you're basically doubling whatever it was is probably not a greater risk.
Great. Thank you, Dr. Lockshin. So we have a follow-up question to that. Do we need to have COVID-19 testing done before we come into a scheduled appointment? And if so, where should we go?
The different places have different rules about that. And they also have different places. So New York, you cannot just walk in anywhere and get the tests. At special surgery right now, people in certain circumstances, for instance, if there's a chance that you're going to be admitted, will be tested on the spot, and so on. But every place is different, and it's changing every day or every 2 days and every 3 days. I think I probably said this before, but I get the hospital for special surgery physicians get, and the New York Hospital, New York Presbyterian Hospital physicians get twice daily updates of what the rules are. So I can't give you an answer here. It may be different tomorrow and so on.
Thank you, Dr. Lockshin. That's a good point. It's quickly evolving information. So we have another question that came up about physical symptoms. My temperature fluctuates daily and weekly between 97.7 and 99.9. I am new to taking daily temperatures. How does this correlate to lupus flares?
Well, you're pretty much normal. The 99.9 is just touching where we start getting worried. It is. People think of normal temperature being 98.6, but actually if you're asleep, it may be down in around 95 to 96. And in very active midday, usually it goes up to 99.8 or something like that. That's why we have, if you've ever looked at a hospital chart, we have temperature curves. We pay more attention to that. Now, lupus can cause temperature, infections cause temperature, and so on. So from what you're suggesting, you're probably normal and don't need to worry much. But if you cross the 100 mark, then I'd start asking some questions, touching base with your doctor about your prior history and so on. If it's a long-standing issue, it's not the COVID-19. From the COVID-19 is, if you're exposed to it, you will be sick within 2 weeks if you're going to get sick. So if it's more than 2 weeks, it's not COVID-19.
Okay. And just another follow-up regarding just the current environment as we begin, or as the state begins to reopen. The advice I got at the beginning of the shutdown was to stay at home as much as possible. Is it safe to go outside, particularly now that New York City is starting to open up? And what about going to the laundry room or the package room? My building has several COVID-19 cases, apparently.
Again, really, really individual. My apartment has sent out warnings. They have people who are cleaning the elevator knobs and the laundry room 3 times a day there. Protect yourself as much as possible. Outside is absolutely fine if you're not in crowds, if you can maintain the distance. It probably is healthy. I mean, I'll tell you again, I just relieve my brain. And as soon as this is over, I'm going to do it again, is just walk out in the sunshine. It helps your mood. So do it in the safest way you can. But assume right now, and probably assume through June 1st at least, that New York is going to be a high-risk area.
Great, thank you, Dr. Lockshin. So we received a question regarding a specific study. It mentions that the Lupus Research Alliance announced that they're working to design and run a clinical trial into whether Plaquenil and other therapies for SLE can prevent or ease symptoms of COVID-19 in SLE patients. It's saying that the study had found that no COVID-19 cases among the 800 lupus participants in the study. So they're asking if you have any updates on this study and if there's any involvement in the study as well.
Okay, so first, there are many studies, not just one. Second, we are doing them at New York Presbyterian and HSS. Well, the reason I keep saying that is that medically ill patients from HSS will be hospitalized at New York Presbyterian Hospital. Third is that it is simply wrong that lupus patients on hydroxychloroquine don't develop COVID-19. We have several patients like this, and others are reporting it. And fourthly, the data are being rapidly collected right now. Dr. Barbaya at our institution is doing a phenomenal job of getting this. We don't have answers yet, but we will. And just keep looking for it because we're trying to get this information.
Great, thank you, Dr. Lockshin. So we have about time for 2 more questions. This question came up earlier as well, and you covered part of this in your presentation. I've read recently about the negative side effects of Plaquenil on the heart when being used for COVID. Is this a concern for lupus patients who have been taking this drug specifically for over 15 years?
Yeah, all right, so I'm gonna give a couple of answers. I was a little startled when the newspaper reports started coming out about the heart problems. Plaquenil is one of the safest drugs I've ever prescribed in my entire life. We are virtually no concern for that, mostly in the lupus and rheumatoid arthritis patients in which we use it, probably because they're young and so on. What we've learned subsequently is that older patients and patients simultaneously taking azithromycin or Zithromax, which has been given, are developing heart problems. And the Brazilian paper that was often mentioned used 3 times the doses that we use. So first is that except in older, much sicker patients with known heart disease, taking azithromycin, I'm not worried at all. The second part of the question was if I've been taking Plaquenil for 15 or 20 years. Well, one of the things that happens, and there's a little history here, Plaquenil was used from the 1960s on by a handful of physicians in rheumatology. It wasn't really until the 1990s, and it was generally used mostly for skin rashes and not much else. Somewhere around the 1990s, the idea became more popular that it was actually doing something beneficial for all lupus patients. So what it ends up with is it's only been since 2000, 2005, something like that, that the drug has showed up. I don't know if I'm visible anymore. My phone just showed something changed.
Your camera may have.
Yeah, what happened, apparently I got a telephone call, so, and that interrupted me. Okay, am I back on now?
Yes, you're back on, Dr. Lockshin.
Okay, so the other issue is we've got only about 20 years of experience of large numbers of patients taking Plaquenil or hydroxychloroquine. So far, a very, very small number have developed a different type of heart disease that's called cardiomyopathy, and that's in the 1 in 1,000 things. The concerns about the eye toxicity have gotten less and less over the years. We do see things like skin pigment occurring in people who have been taking the drug for 20 or so years. These are all separate issues, but they are not extra risks for COVID-19 patients, and they are not reasons to discontinue the drug. There is a paper out which I contributed to, which was run by Peter Ismerly at New York University, looking at discontinuation of Plaquenil in older patients. And it looks like it was safe to do in patients who had been on the drug for 20 years and were apparently doing well. but those are details. If you're considering stopping the drug, again, talk to your doctor, please.
Thank you, Dr. Lockshin. So we're out of time for questions, and I'd like to thank everyone who did submit your questions to Dr. Lockshin. And Dr. Lockshin, thank you for your thoughtful responses. For the questions that we did not get to today, we will be working with Dr. Lockshin to provide a summary of those responses. So please look out for an email from us, and we'll be able to share this information with you. At this time, before we conclude, I'd like to encourage you all to please spend a few brief moments completing our program evaluation. That link has been embedded into the chat box. Again, your feedback is incredibly important to us, to Dr. Lockshin, to help us inform our future programs. And as everybody completes our evaluation, I'd like to invite you to our next program in honor of Lupus Awareness Month. On March 21st, Nancy O'Brien, who's a certified yoga instructor, will be conducting a mind-body workshop and leading a series of deep relaxation and breathing techniques to help minimize patients who are coping with chronic pain. So that registration link will also be embedded in the chat box shortly. So we hope that all of you can join us. Dr. Lockshin, I want to thank you for this incredible highlight of all these important key tips for lupus patients during the time of COVID-19. It's been incredibly helpful.
It's helpful for me, and it's actually, I'll say again, really nice to see some of my favorite people pop up as in the chat box as well. I wish you all really a wonderful summer, and we all hope this is over soon. And thank you, Priscilla. Thank you, Jillian Rose, because I think this is a wonderful session.
Thank you again, Dr. Lockshin, and thank you everyone for your participation today. Happy Lupus Awareness Month, and we hope to see you on May 21st. Take care, everyone.
Okay, bye-bye.